Well, good morning or good afternoon if you're on the East Coast. Welcome everybody to our Crisis Jam after a week off. And pretty powerful quote on the screen that's going to come into our featured presentation today from Ken Norton in NAMI, New Hampshire. Now, I was talking to my wife last night about, we've been to the ED probably a dozen times at minimum over the last 10 years. Our son's had asthma. There's a host of different issues. And I'm trying to think of the longest time we've ever waited. And I'd encourage you during the next few minutes to think about if it wasn't now, if you've been to the hospital related to either yourself or a family member with a psychiatric emergency or substance use or mental health or suicidal crisis, that's a different situation. But for medical, it's likely that you do remember spending 3 hours, or some of you 5 hours or 6 hours, and thinking that was unbearable, intolerable, and inappropriate as you're waiting to get care. I think the longest we can remember waiting was 45 minutes or an hour. Now, a little different when a child is having a breathing problem, and they are more apt to sort of move someone back into getting some stabilization and treatment. But looking forward to bringing Ken on board. Karen, let's go to the next slide. We do have, thank you so much to Megan and Brian. We have now connections with all 50 states in the Office of Behavioral Health. Last 13 or 14, I think, that we're missing, we now have some engagement and connection to. But if you've got an iPhone watch and you're used to the language of closing your loops, now we're working on the participation and collaboration with state Medicaid. So we now have 7 states where not only do we have Office of Behavioral Health leadership, but we also thank you for all of you who are Medicaid leaders joining alongside and working together. We've now got a mailing list of about 490. So if you are one of those state commissioners that we just connected with and you'd like other members of your team to join this meeting, you can forward the invite. Feel free to do that. But if you send us the emails, one, we'll have those individuals in our routine calendar item, but they'll also get the weekly update that gives the information, the presentations from the meeting. So help us build that mailing list. And right now we've got an average weekly participation of about half of those of you who are on the mailing list. We're averaging about 250 of you in this call right now. We also have not given much attention to, we've got some international collaborators that are joining us. And I want to, Jamie, let's see if we can't connect those folks into this meeting in some kind of featured way as we go forward. Karen, next slide. Again, if you've missed a meeting, the Crisis Talk website has a tab in the upper right, Learning Community, where all of the presentations, the tools, the questions, quotes, and now videos of the meetings are available. And give us feedback. We were finally starting to figure out Teams right at the end, but this new Zoom platform, we're hopeful will solve some of the challenges we had with delayed PowerPoint slides and people not being able to get into the chat. I think we were pushing the upper end of our version of Teams, given the number of participants. So give us feedback on how to make this work better, and we look forward to improving it as we go. Next slide, Karen. So Stephanie, Shelby Rowe introduced us to Dr. Anitra Warrior from Nebraska, and just loved your Crisis Talk interview this week.
Thank you. Yeah, so I spoke with Dr. Anitra Warrior. She's the lead clinician of Morningstar Counseling and Consultation in Nebraska. And most of her clients, they're primarily from the Santee Sioux Nation, the Winnebago, Omaha, and Ponca tribes of Nebraska. And she talked about her own experience navigating getting therapy after the tragic loss of her daughter, and how every time she tried to incorporate her culture, her traditions, she felt that she was pathologized. And it really inspired her to go and actually get her PhD. And I think she started initially working out of her home on the Winnebago reservation. And she found that other people felt similarly. And so the way that she describes it, I thought this was a fantastic quote. She said, we view our approach as decolonizing behavioral health and going back to incorporating our cultural beliefs. And that the other point that she made, and another highlight, and Shelby can go a bit more, Shelby Rowe made the introduction, and she can go a little bit more into some updates, actually, some good news, but on a text line. But one thing that she was talking about is how very important it is for states to really consider tribal communities, because she pointed out that if she calls 911, if she's on a reservation, she calls 911, the first question she's asked by the 911 operator is, are you on a reservation? And if she says yes, she's directed to call her local police department. And she explained in terms of integrating a crisis system with 988, how are tribal communities going to be considered, which I think is not just an important question for Nebraska, but for all states. So, and Shelby, maybe you could dive a little bit into some of the updates with the text line as well.
Sure. I am so glad that that you all were able to visit with Dr. Anitra Warrior, and I really encourage everyone to read this, especially those who work in rural communities, because I think you'll see a lot of similarities and a lot of the questions that many of us have had related to 988 in rural America. Anitra really highlights, Dr. Warrior points out kind of those special circumstances. And as you mentioned, Stephanie, you know, why it is so vital to loop in your tribes as you're planning your 988 is we take for granted that like 911 and emergency services are there for all American, you know, for everyone in the US, but that is not the case on reservations. And so it's worth it to be more proactive and reach out and build those relationships. I know in my state where I'm located, a lot of our tribal police are cross-deputized with their county. And so those services can be seamless. And so things like that I would encourage for other states to look into as well as we're looking for rolling out 988. I think one thing that she really points out, I love, is it's not modifying, you know, it's not making individuals in crisis fit to a system. It is adjusting the system to better meet the needs of those individuals that they're serving in crisis. And it's not, you know, I've been long impressed with, you know, at RI, when I first got my tour and Paul gave me a tour, everyone is their guest. And I think Dr. Warrior's program takes it a little further, that everyone is family, everyone is a relative, and to respond, you know, take that extra step for everyone that you're working with and how that makes a difference. And I think that'll resonate for those of you that are like, well, I don't serve tribal populations. If you serve rural or you serve people in the community where you live, I think you'll find a lot of wisdom. And then it's exciting because they're not covered by 911. Dr. Warrior is working on creating a crisis text line to serve the tribes that she works with. And we're really hopeful and encouraged that will expand, and that perhaps we can get linked in, you know, for a phone hotline, things like that, but stay tuned. But I think the philosophy and the skills are behind, and she is really leading the way in adapting, you know, providing those cultural adaptations for evidence-based practices. So I can't speak more highly about her. Everyone, please read the article and feel free to reach out to her. I think that she's someone we should be listening to more on the national level. And that's the end of my PR pitch for Dr. Warrior, but please read this article. She makes some great points.
Thanks so much, Shelby. And thanks, Stephanie. I think, Shelby, you first brought to me that Dr. Warrior's team was taking tacos out and meeting with people in crisis. So just the creativity and the connection was superior. Next slide, Karen. And Dr. Warrior will be our featured presenter. Oh gosh, I'm not remembering the date right now, but it's later in July. Just our quote of the week. And Karen, let's go back and capture that quote from Shelby about fitting our services to support. That certainly will be a quote in a future Crisis Jam. But back when we were doing, Richard McKeon remembers back in 2018, at the end of the year, we did this planning session around what was then called N11 before we knew it was going to be 988. And Dr. Sandy Schneider referenced this recent survey of hospitals. Dr. Mike Hogan, I see you in the video, my partner on the Crisis Now. I think, Mike, when you and I saw this, it's just stunning that we're still in a situation where a recent survey of hospitals in 2018 showed that 20% of those hospitals, at the point they answered the survey, were holding a person who'd been there for more than 5 days, largely without treatment and simply waiting. Mike, any reflection? Do you remember that quote when Sandy shared that back in 18?
I do. And just to get into this, whole space and to discover or to be reminded of that problem, the problem of implicit neglect that comes up when we talk about rural areas, and the problem of criminalization are just core realities everywhere that we're trying to address, and it ought to continue to motivate us.
Terrific. Thanks so much, Mike. Next slide, Karen. Look, we're here. In fact, Karen, you can take the slides down for a moment. We're here in large part because of the leadership of our state governments, and even more so our federal leadership out of SAMHSA, who literally for decades now has been tilling the ground, removing the rocks out of the field, and trying to put us in a situation where we could really make the progress forward that we have the opportunity to do with 988 and everything else that's going on. So I'm thrilled to introduce Dr. Anita Everett. We actually quoted her last Crisis Jam from that same 2018 meeting, Dr. Everett, when I first heard, you were the first one I ever heard characterize this, someone to call, someone to come to you and someplace to go if needed. So Dr. Everett, thanks for being here.
Thank you, David. And I want to thank you and Brian Hepburn and all of our friends at NASHBID, as well as one of my own staff, Richard McKeon, for being part of the structure of setting up this meeting, which has so clear energy and has served an important role in energizing everywhere across the United States. Our attending here today is really to kind of make it really clear that SAMHSA is very invested in this project and very interested in it. And I think we've been a little bit in the background, but now we're moving more into the foreground with the full support of this administration. So here we are. And as a part of that, what I wanted to do quickly is introduce the members of our team. Although we have not been publicly noisy about all the work that we're doing, we do have a team formed inside. Joint Crisis Team is what we call it, because there are many different parts and funds throughout SAMHSA that we're trying to pull together to sort of reinforce and catalyze moving forward in the whole crisis service enterprise. So you all know Richard McKeon. He's our branch chief of the substance abuse branch, and Richard has been keeping you updated. I've listened in on several of these calls over the year, but Richard's been keeping you updated, I know, with all of the things that are happening. Who else is on our team spam risk call right in the middle of an announcement. Thiessen Thomas. Thiessen is a director of our formula grant division, and he is the keeper of the funds, the administrator of the funds that have been added to the block grant that have created a set aside, so that now every state in the United States has some degree of money to support development of crisis services. And we're hoping that continues as a permanent component of the block grant. And also that other elements of the block grant, which also fall under Thiessen, which have been increased dramatically with the relief money and rescue money associated with COVID, is all under Thiessen's hat and umbrella. And we're doing whatever we can to stimulate the development of crisis services. Also on our team in the lead role is Dr. John Palmieri. He's a relative. We think we've got him learning most of federalese, but he's still sort of working on learning all of our acronyms. John is a community psychiatrist from Northern Virginia and has been with us now for about 6 months and is heading up the Joint Crisis Group and a lot of our joint activities. We have Charlie Smith with us. Charlie is a regional administrator at SAMHSA. He is of the area that is in the Colorado area. It's area 8, Charlie, right? Charlie is helped us engage our regional administrators so that the word gets out across the country through those 10 HHS regions. And we've been delighted to have Charlie with us. is a kind of a quasi detail for the last several months. Melinda Baldwin is also with us today. Melinda is our one who keeps us on task with regards to children's services. Melinda has a deep and wide history with regards to children's mental health services, and she is a division director for us and very invested in doing what we can. At some point in the not too far distant future, Melinda will come to you with an announcement about a convening that we're having regarding attention to children in the crisis enterprises, because we know in many states the children's systems have sort of diverged or they're somewhat separate. We have Eitan Raskus that I know you met a couple weeks ago. Eitan works with us in our leadership. He does a lot of the interface with the high-level government people, including individuals from the White House who are very interested in what we're doing, as well as the Secretary's office and our acting assistant secretary. So Eitan's been very instrumental with that. We have Amy Hudson who's with us, and she worked with Charlie. She represents the students that we hope to stimulate career-long interests in public mental health, as well as the crisis enterprise. And then we have Megan McHugh with us as well. I don't know if Megan, I don't see her. Megan is one of our evaluators. So she has the kind of brain that helps us think about accounting for what we do. I've mentioned already that we have the money that's associated with the block grant that has given states new opportunities to develop and think about planning. We have information that we've asked the states to give us back that's very sort of rudimentary, but it gives us an idea of where the states are planning and what kinds of things they're planning. Thiessen helps us sort of keep up with that. We also today are having a press release together with that announces the sort of a new era of grant with them. As you may know, Vibrant is been the operator of the grant. It's a grantee, but it's through a cooperative agreement that funds the 988, or what will become 988, what's currently known as the National Suicide Prevention Lifeline. That is an important component of the whole crisis enterprise. So that is a press release that's going to be released today. So hopefully you'll read about it in some of your local newspapers as a herald to what over the next year we'll be working very aggressively on. Let's see, I'm going to give my team members a chance to sort of add in anything and then turn over to Richard for his sort of regular report. But I do want you to know that we're here, we're activated, we're involved in what's going on with this community, very interested in seeing that you have the support you need from the role that the federal government has in that. And thanks for what you're doing, and we'll stay tuned. We're with you. Richard?
Yeah, thank you, Anita. I'll just go into a little bit more detail. So the announcement, today for the new cooperative agreement for the Lifeline is a 5-year cooperative agreement starting September 30th, and SAMHSA also awarded a $32 million supplement using COVID funds because of the need for resources as we go toward full implementation of 988. And David, I don't know if you were going to mention it, but I know that the MACPAC report just came out, and so that's certainly something for people to be aware of. MACPAC is the corollary to MedPAC. MedPAC provides the Congress with expert input on Medicare policies. MACPAC does the same thing for the Congress on Medicaid policies. And there is a chapter there on behavioral health crisis services specifically. I think it's chapter, number 2. So I would call you're right. Yeah, chapter number 2. It has some specific recommendations for SAMHSA, for CMS, et cetera. So I'll stop there. Thanks, Anita.
Mute problem. Eitan, you got a quick thing you want to add?
Sure, and thanks so much, Anita and Richard. I think the only thing I would add, which I've mentioned on previous calls, is we're in the process of kind of building out a longer term roadmap that thinks through the different moving parts and pieces around 988. And so to the extent that anyone on this line has developed similar thoughts or input that would be helpful to that end, obviously, please feel free to send that our way. We would welcome and appreciate your input.
Thank you. One other quick thing. So I do see that Megan's with us now, our person with our evaluation brain. If you're in a state or a locality that's developed particularly good elements that you found to be really useful with regards to data tracking, in the federal government, of course, we don't want to set up things that micromanage. We don't need the micro details, but we're looking for things that might help us get a picture of what's happening nationally, mostly, to be honest, so we can identify gaps that need and disparities that need extra attention from our role in federal government. So Megan is down there. I'll put her email in the chat box as soon as I can, or ask Megan to do that, so that if you've got any good examples, good working examples of data collection or a dashboard, which is really what I'd love to have, let me know. Let Megan or me know. Thank you. Thanks, David.
Oh, and thanks to the SAMHSA team. Thanks to Dr. Everett, Richard, Tyson, Charlie, Linda, Eitan, Amy, Megan, and John for all joining us, and look forward to your engagement in both the planning for and debriefing and active engagement in these meetings and leadership going forward. Great. Brian Hepburn, reflections update today.
Yeah, thank you, David. And you look very relaxed today. Thank you. It looks like you brought some of that Maui sunshine back with you. So thank you for doing that.
Thanks to you. Thank you, Brian.
I want to thank Anita, Thiessen, John, and Richard and their team from SAMHSA. I think their leadership has helped us in the past and will help us going forward. Also, congratulations to SAMHSA and to the groups who have been supporting this effort. It's very impressive. But also, David, want to thank you. Much of the success goes to you and your efforts for this learning community. So thank you very much. The states continue to develop post-COVID strategic plans, and we really like saying that, even if it's a little premature. Post-COVID, it just sounds great. But the states are integrating lessons learned during the past year, along with their pre-COVID plans and with 988 and crisis services. They're using the SAMHSA national guidelines for behavioral health crisis care to move their crisis services forward. They're using the NASHPD model legislation, which was created with the help of many of the groups that are on this call, and customizing the model legislation to fit their own states. They're integrating an equity focus throughout their strategic plans. And they're using the supplemental funds from the COVID relief plans to move ahead with first episode psychosis, 988, and crisis services. It's a very exciting time. So thank you, and we look forward to the continued effort. Thank you, David.
Great stuff, Brian. And we're going to start using that post-COVID 988 era. I love that language, so we'll keep running with that. Karen, just for lack of time, I was going to ask if anybody from Arizona Medicaid was on, but I think we'll save that for another time. But let's just tee up the slides so people know what's in the deck. Yeah, this was in your email this morning. If we can bring up that prioritizing slide. So Arizona Medicaid did convene a community stakeholder virtual meeting, and they went through a full, I believe the software package is called Canva, but they did a SWOT analysis, and you'll see the top sort of areas that came out of that pretty broad community stakeholder meeting. And in the coming slides, you'll see, again, you've all been in meetings where you did this on the wall or on the whiteboard, but Karen, just slowly go through these next slides. You'll see that they conducted a process of everybody putting ideas down, voting through those, prioritizing those, the strengths, next slide, the weaknesses, more weaknesses than strengths. So we're always looking for how far we have come up that mountain and how far we yet have to go, opportunities, and then finally threats. So it was a pretty nice little process that they conducted with a broad set of stakeholders in Arizona as they were thinking about 988 and the crisis continuum and the work that's already been done in Arizona and that yet to do. Next slide. Sarah Corcoran, we've been continuing to sort of update this tsunami wave with all of the sort of context and the Zeitgeist that's got us here, as well as the funding to support 988 and other crisis services. I'll at least tee up, we do have two slides in here, one on Tom Betlock's testimony, I believe, Sarah, was yesterday, as well as the MacPac report that Richard referenced. But other thoughts to start before we go to those slides?
Yeah, it's been a busy couple weeks on the Hill. Just to flag for everybody, the House Appropriations Committee rolled out their schedule for markups for their appropriation bills for FY22. So the date to circle on everybody's calendars, because I know everybody's looking forward to a great markup, is July 7th, and that will be the HHS, labor HHS markup. Infrastructure conversations are still ongoing, so we're not quite sure where that is going to land. I know that was an open piece a couple weeks ago as well, so we're monitoring that. And as David mentioned, it's been a busy couple weeks for hearings on the Hill. Secretary Becerra made the rounds last week and is continuing that this week for the FY22 budget request, as well as a HELP hearing last week for the Assistant Secretary Miriam Delphin-Rittman nomination. And then yesterday, our returning champion Tom Betlock also appeared with a slate of other witnesses in the Senate Finance Committee for mental health and substance use specific hearing. So it's been a busy time on the Hill, and I think that tees up the next slide pretty nicely. Now, I'm not sure if this is a clip or not. David, is it?
It's not. I didn't think we'd have the time
Great.
today, but maybe you can drop those links into the chat, Sarah.
Yes, absolutely. So I will drop the clip into the chat. It was a great hearing, and you know, there has been actually a smattering over the past week, even before leading up to this hearing, of discussion on these issues in the different committee opportunities. So I'll include that in the chat. I also did drop the link to that MacPac report to Congress that was released yesterday as well, yesterday morning, and Chapter 2 specifically, as was mentioned earlier, is that key chapter. But I would encourage people, when they are looking for a nice summer beach read, it's about 274 pages, I believe, so it'll go pretty quickly, but a lot of great recommendations in this report, and very helpful moving forward on the Hill to have this document as a big discussion piece.
And Aaron, I had hoped to have the time to tee up a couple of comments, but given where we're at right now, if you don't mind, if you're with us, just dropping some comments in the chat, and let's get some time for you to reflect on this next time. Sarah, anything else that you'd add?
I think that's it. I'm always happy to answer any questions. Also, if there are any questions that anybody wants to put into the chat in the interest of time, but I'll provide what resources I can, but a lot going on, and excited to see what happens in the House Appropriations Subcommittee in July.
Richard, any comments or questions for Sarah before we move on?
No, thank you. It's always very important information.
Connor, I got your email, and I apologize, I didn't get the updates to the AFSP legislation tracking into the document, but do you want to give us an update?
Sure. I just want to flag a couple pieces of legislation that have been introduced over the past couple of weeks, including the Law Enforcement Training for Mental Health Crisis Response Act. That's HR 3595 and S 1837. To authorize grant program funding for law enforcement agencies and corrections agencies to obtain behavioral health crisis response training. And then the Behavioral Health Crisis Services Expansion Act, S 1902. That is Senator Catherine Cortez Masto's comprehensive crisis response legislation that would provide national definitions for behavioral health crisis services, support expanding coverage of these services, and also supports the crisis continuum infrastructure and integrating traditional emergency response into behavioral health crisis response. I can go over the details more fully next weekend or next week. And in the meantime, if you need any additional information from AFSP, please reach out to Taylor Wolf and Natalie Tejan, who will be covering for me once I offload. Thanks, David.
Terrific, Connor. And Connor, I'll get that into the deck, and let's do that. Let's get more detail next time. And let's also just carve out the time to spend a couple of minutes with your colleagues who will be more actively as we grieve Connor going to law school and being in these calls as more of a guest than a regular participant. Let's go to the map. And Laura, who's been doing such a terrific job with the Vibrant team, is not able to be with us today. But Angela, are you with us to highlight the number of states that have changed colors over the last 2 weeks?
Hey, David, I'm here. So you probably already know Nevada and Colorado both passed bills. Colorado is still waiting for the governor to sign theirs, but we don't anticipate any problems with that. We're just expecting actually a signing ceremony. So Colorado will turn green, we think, relatively quickly. The big news, Oregon actually referred their bill to the House Ways and Means last Wednesday, and New York last week passed their bill in the Senate and then by the Assembly. So right now, that is actually headed to the governor's desk. And both the Oregon and New York bills are somewhat similar in that they set up a study and recommendations. I think Oregon's is due by January 1st of 2022, New York's bill by December 31st of this year. New York's is rather explicit in sort of setting out a framework of crisis services and asking for recommendations on what kind of fee is needed to really finance that continuum of care. So that's where we're at right now, and open for any questions.
Angela, this is really terrific, and so appreciate NAMI continuing to share the detailed tracking that you're doing state by state, as well as the link that we've now shared that where you're posting the actual legislation that's been signed and finalized. Angela, still any thoughts on, after we finish this major legislative session season and are moving into our next range, how we begin to use this map to identify substantive support versus, I mean, it's not that if the state has passed something for additional work, that's great, but Utah, Virginia, Washington State have put really substantive things on the table. Are you at NAMI thinking about how to sort of track this and measure this as we move forward?
That's a great question. Yes, we are. And actually, I have to give credit to our many allies. So there are a number of organizations that are working together. We're actually coming together within the next few weeks to strategize around 2022. Because the reality is we want to turn this entire map one solid color with everybody having access to that continuum of crisis services. And so there'll be two parts. One, figuring out how do we move forward, every state forward, and then how do we ensure that states that have passed laws are actually moving in the direction and implementing in a way that's helping people who live with mental health conditions.
Terrific, Angela. Thanks for your leadership and those organizations that you and NAMI are working with. It's time for
Hey, David, this is Becky. Can I make a real quick comment?
Yeah, go ahead.
Hey, so is there a way to because we're capturing people, states in legislation, including whether they're levying a fee in that legislation. But what I'm hearing in some areas is that states are also looking at funding some of this through the 5% set aside and some of the other funding that's coming, that's kind of raining down on the states. Mm-hmm. Lots of money's flowing out the door, so that states are not only looking at fees versus no fees, but they're also looking at all these other funding opportunities that have popped up, a lot of it because of COVID. Is there a way, and I don't know if Brian has the mechanism to garner that information from the states, but I think we're missing some good intelligence by not looking outside of how states are planning to at least get this bike out on the road, maybe with some training wheels on it, using other funding opportunities that are out there so that we all can hear what everybody's doing financially outside of just looking at did they do a fee or they didn't do a fee. Does that make sense?
Yeah, no, it makes sense. Of course, Utah's isn't a fee-based situation, the first one that was passed. Angela, any comments or thoughts on Becky's question as we're attempting to cobble together the resources to do all of this?
I think it's a great question. And honestly, look forward to partnering with SAMHSA and our allies to figure out how we might be able to make some progress in that direction, Becky. As you can imagine, enormously complex to understand where each state is at in terms of not only the baseline of what services they currently have, but how far are they progressing towards our ideal? And then secondly, as you pointed out, there are multiple funding streams that can be used to get there. How states use those funding streams is going to vary widely. I don't know that anybody currently has the resources to track all that, but we will have those conversations because I think it is one of those key variables that make a difference.
Angela, this is Richard McKinnon from SAMHSA. So we'd certainly be happy to have those conversations with you because it's something that we are, of course, very interested in. We're interested in understanding as fully as we can the resources that are needed to implement 988 effectively, but also where we think that that those resources might come from and how close it may come or not come to meeting those needs. So a couple of things we have done. We've worked with Vibrant to get a sense from the crisis centers about how much public funding they were getting specifically for answering Lifeline calls. And so we've gotten some information from them. We're obviously tracking on the laws through the great efforts that you have been making. And Thiessen Thomas, who oversees the block grant, has been tracking on what states are saying as far as the 5% set aside is there. But there are there are a number of different funding streams, and trying to capture all of it is challenging. Would certainly be happy though to have a conversation with you about how we can share information or combine forces or together get the best possible handle on how close are we coming to the resources that are needed.
And that's
just real quickly from NASPID, every state is working on these issues, whether we're talking about block grant or enhanced FMAP. I think part of the question, though, is how are states going beyond the minimum? Because every state will be using block grant funds for crisis services. They'll all be taking advantage of the FMAP. But there are some states, it's very interesting. We had a call with California yesterday. They're using this as an opportunity to really move forward much beyond minimum. So I think it's fair to say every state will be achieving the minimum. What we might want to do is take a look at those states that are really going way beyond the minimum that we could highlight as models across the country.
Terrific, Brian. Great stuff. So tease up well the 5 seconds of crisis calculator, where we're really looking at thinking through the mobile teams, the crisis receiving centers, crisis stabilization, what those costs are, and how those are paid by Medicaid, commercial payers, Medicare, et cetera. Tom, I know that you and Paul were going to spend our third session driving into home and community-based services. I think given the time situation that we actually take 5 seconds for the 5 second calculator today and punt that to next week. But Tom, I would be interested in just a couple of comments from your testimony with the Senate Finance Committee yesterday.
Sure, David. Thanks for the opportunity. It was really a historic moment. And when Senator Wyden said that it was only the second time in the history of Senate Finance where they have had a meeting on mental health issues. So I think just it goes to show in terms of the conversations we've been having here about the unique moment in time in which all of these issues are being focused on in a way they never have been, and resources are being put towards them. And clearly, senators understood the fact that there are some resources available, but there's more work to be done. And so it was a great opportunity. I certainly was an honor and a privilege for me to be able to be there and talk about not only crisis as it's evolved in Arizona, but the opportunities nationally to talk about physical health and behavioral health integration. So again, just a great opportunity, and expect more follow-up in terms of where Senate Finance is going. I just, David, want to acknowledge SAMHSA in terms of their leadership for helping on this call, and also Brian Hepburn and his team. I mean, you and I probably a little over a year ago talked about how we come up with a learning collaborative around crisis care, never dreaming it would be 200 plus people gathering together on a weekly basis to be able to talk about these issues. So thanks so much to our federal partners and to Brian and his team and the Medicaid folks for participating in these calls.
No, it's terrific, Tom. And it's been at least that long, maybe longer, when you first mentioned to Paul and I that Medicaid does that. You called them affinity groups all the time around special issues. And we just didn't know how to move that forward. And SAMHSA and NASBIT have made that happen. Tom, just Karen, if you can bring up the slide, we will come back to this one more time next week. But Tom, you've talked about tens of billions of dollars being available through the home and community-based services, and you've teed up these 5 questions. So where do you think you'll go next week, Tom, as you and Paul look at this? Which question will you focus on?
So we've teed up 3 last time, and really focused on the guidance from CMS in terms of what some of the different strategies are that states may be looking at, whether it's increased provider rates, increased capacity, increased ability for data systems to talk. I mean, CMS really lays out a number of different strategies. What I'd like to talk about next week is going back to number 2. You know, states are still in the final throes of developing their plans to be able to submit it, but the timing issue of when the dollars get spent is so critical. You know, I was sort of working through this back of the envelope with one state, and it was a difference between 200 million and 400 million just in rehab option services only, in terms of what the available increase was going to be, depending upon the timing. If you spent it more quickly, it was $400 million. If you pushed it out, it was $200 million. Right. Meaningful differences, but time becomes an issue in all of that. So that's the issue I think we'll focus on next week.
Great. Paul, any quick comment?
No, I think I love Tom's approach. I think what he's thinking through is giving us some very concrete examples of the impact, right? This is potentially, Tom, keeping your state budget neutral and having 200 million more to spend in different areas of service, including crisis care, right?
Exactly.
So in next slide, Karen, actually, let's skip ahead to the main. Thank you, Tom. Thank you, Paul. In 2014, Washington State had a landmark Supreme Court ruling around a lawsuit that included Pierce County for individuals waiting days in a hospital emergency department. And we had a similar finding of the New Hampshire Supreme Court earlier this year. The story of how that happened and the work, I called it in the email this morning, gentle pressure relentlessly applied by Ken Norton and the team at NAMI New Hampshire and their partners. Ken, welcome. Thanks so much for being here, and tell us the ongoing story, which is one still moving as you and your team are working with state leaders and others to make a difference.
It is great. Thank you for being here. And I echo Tom's comments about your leaderships and Brian's and SAMHSA's. This has been a great learning experience to be a part of. So this was a quote I used in a press conference that we held in January of 2013. We had met with then Governor Hassan on her first day in office, the Friday before this Monday press conference, to talk about what was an emergent crisis. And we were joined at this press conference by 15 stakeholders. And this has been, kind of the quote that we have used all along since then, that, wrong medically because it denies people access to immediate mental health care, legally, a variety of legal issues, but under New Hampshire law, our interpretation that people in a mental health crisis should have immediate access to mental health care, ethically because it's doing harm to people, morally because we don't do that with any other medical condition, life-threatening, and economically because it's very costly service and there are much more effective, less costly services. So next slide. And, there was a lot that kind of led up to this, but suffice it to say that that we had a new 10-year plan in 2008 that was never put forward and funded because of then the recession. And then the Federal Department of Justice sent a letter of warning to New Hampshire in 2011 saying that we were in violation of the Olmstead Act. And the legislature at that time was kind of a Tea Party legislature. They ignored the letter. And in 2012, advocates filed the mental health federal class action suit in federal district court. They were joined by the Federal Department of Justice. And that suit did not mention emergency department boarding because it was really not an issue at that point, but it was certainly emerging in 2012. And by 2013, it was a full-blown crisis when we had that press conference. That lawsuit settled in 2014. And, part of that settlement included our first mobile crisis teams in the state, 3 of them. But we kind of went into a situation where, and I'll show you the data in a second, but the crisis continued to escalate. In 2017, we had a new governor, Governor Sununu, and he, in his first few months in office, I met with him, showed him the data, and he went personally to an emergency department without press in tow, talked to the individuals in the department that were being held, talked to the staff, talked to family members. Senate President then went along, other legislative leaders, and they vowed to move mental health forward. They brought forward House Bill 400, which added additional mobile crisis teams and DRFs. They asked to have a signing ceremony here at NAMI, New Hampshire. Big celebration, and shock by 6 months later when no one responded to any of the requests for proposals for those additional services. So there were more, situations that occurred, but in 2018, then the ACLU filed a John Doe federal class action suit in federal district court, and that's still ongoing. I want to give a shout out to SAMHSA and Dr. Richard McKeon. Richard came and visited New Hampshire in January of 2019, right as our 10-year plan was rolling out. And his visit was instrumental. He was coming up to the VA here in Manchester, and he piggybacked and met with legislative leaders, governor's staff, and leaders from our Department of Health and Human Services. And I think it was instrumental in getting funding during that legislative session, $200,000 for suicide prevention efforts. And we have on this call Jennifer Sabin, who was recently hired by the Bureau of Mental Health Services with those funds. And also $250,000 for Headrest, which is our Lifeline center in New Hampshire. There had previously been no state funding for that. And then also in 2019, we had a 10-year mental health plan, and that was led by Julianne Carbon, who I think is also on our call, who's our lead at our Bureau of Mental Health Services, and strong bipartisan support from the legislature relative to that. But quickly impacted by the pandemic and COVID, and a lot of the legislation, including what should have been statewide mobile crisis, Senate Bill 14, although specific to children, never really was able to be rolled out and is rolling out now. And obviously, we don't know the long-term impact of the pandemic, but certainly we saw a spike in boarding, and that led to this Jane Doe Emergency Department boarding appeal. Next slide. One thing I love about David is his use of data to inform and drive practice. And I have seen that as a member of the Lifeline Steering Committee. We use data throughout this process. What you're looking at is a slide from April of 2015 until the end of May. And the black is adults and the blue are children. And it's the number of people being boarded in emergency departments in our state on any given day. And want to give a shout out to our Department of Health and Human Services, who has made this information available to us and helped us to utilize it as a leverage point with our legislature and from advocacy efforts. Next slide. We use this data a lot in our social media. We twice a week post to social media what the current count is, and those social media posts get more activity and sharing than many of our other posts. Next slide. And so the Jane Doe decision occurred in there was a habeas corpus filed in 2020 by Jane Doe after being detained 17 days in an emergency room without a hearing. And they cited a federal court ruling on the state's motion to dismiss in the federal lawsuit case. And although it wasn't a ruling per se, the judge in that case, in denying the motion to dismiss, made very specific statements about due process. The habeas corpus was granted. The state appealed that to the New Hampshire Supreme Court. Briefs were filed in January of 2021. NAMI New Hampshire filed an amicus brief. We didn't take legal position per se, but talked about the human impact of boarding, and the oral arguments were in March. One of the Supreme Court justices during those oral arguments referenced that this was a Kafkaesque situation with people being held undetermined amounts of time with no due process. And in May, there was a unanimous decision by our Supreme Court affirming the lower ruling, and essentially saying that people were entitled to a due process hearing within 72 hours of being detained. And I think, reading between the lines, more importantly, that people in a mental health crisis under our state law should be immediately transferred to an inpatient setting. On the day that that occurred, there were 43 adults and 26 children being boarded. Next slide. Since that time, within 48 hours, Governor Sununu issued an executive order to address the mental health crisis and did a number of things, including granting emergency rulemaking to the Department of Mental Health Services and incentivizing creation of more designated receiving facility beds that could accept involuntary patients, and also for nursing home beds to take geropsych patients out of our state hospital and open up room for additional beds. There was also additional funds for transitional housing, and there was kind of a separation during that time that children didn't count in the involuntary count because they were being held by the authority of their parents. So they weren't, or guardians, weren't entitled to due process hearings. Next slide. And so, 1 week after that, the governor convened what has been an ongoing emergency department boarding stakeholder meeting. That meeting was already planned. He had accelerated it a little bit. There was a review of the executive order and some pretty intense conversation about accountability and really pressing the hospitals and our community mental health centers to do more. 2 weeks later, the Department of Health and Human Services filed a medical protective custody bill that would have allowed detaining people for up to 7 days in emergency departments. And it was really unclear. It was late in the legislative process. It was based on our mental health involuntary emergency admission laws, but they claimed that it was really more for people that didn't meet mental health criteria, but were a danger due to substance use intoxication or dementia or other organic brain injuries. It was scheduled for a hearing. There was a 2-hour-long hearing. It would have required a 2/3 vote in the Senate and House to suspend the rules if it had come out of the committee, and the committee voted it inexpedient to legislate. When I put this PowerPoint together a few days ago, there were 2 adults and 17 children waiting. Today or yesterday, there were 6 adults and 15 kids. So some major action in bringing those numbers down in a short period of time. Next slide.
Terrific.
And then, just how that all ties into mental health crisis care in New Hampshire, that, the 10-year plan that we have is still a very strong plan to reform our mental health service delivery system, including the crisis response. This 2019 Senate Bill 14, the mental health centers are currently in the process of contracting, and all regions in our state will be required to provide statewide mobile crisis. There's a procurement underway that I believe was announced this morning for a centralized call center. And then thank you to Vibrant. We received the 988 planning grant, and Jennifer Sabin has been one of the leads on that planning grant implementation in our state. We're meeting regularly and have subcommittees, lots of things happening in the 2021 legislative session. Our committee of conference is meeting in 5 minutes to finalize the budget, but significant increased funding for mental health services and both community-based supports and some limited inpatient capacity and crisis time intervention. So that's kind of the upshot of the Jane Doe decision in New Hampshire.
Ken, this is tremendous. And Mike used the phrase implicit neglect earlier. And Mike, as I think about that, I think what we tend to do is we know that there are situations like the woman who was in the ED for 17 days, and we think that's horrific. We talk about the human impact, but then we just assume, we just cannot get our brains around that that's a common occurrence and that these are just outliers. So Ken, your use of data to day by day look at, this is the number of people waiting, this is the number of adults, this is the number of children, and then to track that and put that out into social media has, to me, laid groundwork for this change that would not have happened otherwise. So just amazing, amazing work. We've got a roundtable. Let's start next slide, Karen. Let's go to Jennifer first. And Jennifer, I know you're new in this role, but not new to the challenges in New Hampshire. Reflections, comments.
Yeah, I'll just start by saying that, my position at the Department of Health and Human Services as the statewide suicide prevention coordinator, to Ken's point, has never existed before. And I'm really excited that through the long-standing advocacy in the suicide prevention community and the crisis community, that my position now exists. And it's an exciting time to be doing this work. Our director, Julianne Carbon, is also on the call today. And through her guidance, we're really going through this crisis redesign, right? So statewide mobile crisis across the lifespan. We've never had mobile crisis anywhere in the state for children before, and that is coming to New Hampshire. And again, a lot of the groundwork through the 988 system, not just thinking about it as the phone number, but really this whole system of someplace to call, someone to respond, and somewhere to go, really taking that on. So for me, in my new position, I've been with the department for just over 2 months, but it's really exciting, and we owe a lot of it to the advocacy that Ken has done over the years with lots of different partners. So happy to be here.
Welcome, Jennifer, and thanks for those terrific comments. Kana, you've had both personal experience that we addressed in a prior call, as well as national leadership roles in tackling this challenge. Any reflections on hearing Ken's story? Kana, are you with us?
I am. Can you hear me?
Yes.
I took a screenshot of that data dashboard, and I've been sending it to everybody to say, look, this has spiked through COVID, and it's not necessarily getting better. So it's even more imperative to take action. But yes, the boarding is obviously extremely relatable after spending, almost 70 hours in an ED, waiting for suboptimal care. So really excited to see this evolution.
Terrific, Kana. Thank you. Shelby, what are your reflections as you hear this story?
So as I listen, we always talk about a suicide crisis being, this is a life-threatening medical event. And I can't think of any other life-threatening medical event where we involuntarily hold people against their will. So that our default action is legal and criminally punitive is disconcerting on multiple levels. And then I also think just the therapeutic value of that for someone who is a suicide attempt survivor and talks to many others, that state of acute risk is going to fluctuate greatly in that time period. So holding someone for 17 days, chances are within 24 hours that they are no longer in a life-threatening crisis. And so I wonder, how often are they reevaluating? And then I think for me, that if they were not still acutely suicidal that next day, after 17 days of being in the ED, how would they not be acute? So this is so inhumane. And so hopefully we can get this shifted, because I've never heard of someone being criminally held for high blood sugar or high blood pressure. So we've got to stop treating people with brain health as if they're criminals.
And, Shelby, I revisited the Supreme Court ruling in Washington State this morning, just thinking about this presentation from Ken. And the defense didn't say, these people are dangerous and need to be in the ED. They said, we don't have the resources available, so they're waiting. that's been our response, is we haven't supported and funded and resourced the services that Jennifer was just describing. So terrific. Thanks so much, Ken. This is amazing work. Thanks for giving this presentation. Karen, let's go to the next slide and just tee up. We've now got quite a, and we're going to be looking to SAMHSA and NASBIT for feedback. And please let us know if you have ideas for featured presentations or content or speakers. We're coming back to a couple of prior presentations with John Franklin Sierra in 2 weeks and Wendy Tygreen on August 18th. They've got some really important follow-up to the presentations they gave earlier. But I'll just point out Dr. Chris Carson. All of you know Margie Balfour, who's one of our key partners in this crisis redesign effort. Her boss, the owners of that company, Dr. Chris Carson, Dr. Robert Williamson, were the ones who brought this idea of direct law enforcement drop-off, immediate access, no boarding whatsoever for someone, and incentivizing law enforcement not to take someone to a jail ever, because it's faster to go to their facility. How did they come up with this, and how did they break through the very significant barriers that have kept us from doing this? So really looking forward to an interview with Dr. Carson next week. But let us know. And if you'd like to be in the roundtable at the end to make a couple of reflections or comments, please let us know. I'm constantly sort of scrambling to put those roundtables together. So thanks so much. Brian, any final comments, and then we'll go to Dr. Everett?
No, another good meeting, and we're glad for the increased visibility of SAMHSA. Thank you, David. Another great meeting.
Great, super. Dr. Everett?
Nope. Likewise, I just want to say thank you. Thanks to everybody who attended. And, one of the things that is very important here is maintaining an energy and a focus on what we're doing. And that really, for me, for all of us, I think boils down to the person. What does the person in crisis need? So thank you for that and for all the work to put this together.
Thanks, everyone, and hope to see you next week with Dr. Chris Carson, another meeting on Zoom. Thanks. Bye-bye.